drowning, hypothermia, and rewarming, emergency management. Drowning is a leading cause of unintentional injury death globally, accounting for an estimated 236,000 deaths annually, WHO, 2023. Hypothermia frequently complicates submersion injury, with core temperatures less than 35 degrees Celsius observed in up to 78% of cold water drownings. Diagnosis relies on clinical history of submersion, hypoxemia, PaO2 less than 80 mm of mercury, and core temperature measurement via esophageal, bladder, or rectal probe. Immediate management includes airway protection, oxygenation, passive and active external rewarming, and extracorporeal life support, ECLS, for refractory cardiac arrest at centers with capability. Key points. Note: drowning is defined as the process of experiencing respiratory impairment from submersion/immersion in liquid, with a global annual mortality of 236,000, WHO, 2023. Hypothermia, core temperature less than 35 degrees Celsius, occurs in up to 78% of cold water drownings and may confer neuroprotective effects during prolonged submersion. The incidence of drowning is highest in children aged 1 to 4 years, with a rate of 2.8 per 100,000 in the United States, CDC, 2022. Immediate airway management with high-flow oxygen, 15 liters per minute via non-rebreather mask, is critical. Endotracheal intubation is indicated if GCS less than or equal to 8 or if respiratory failure is present. Passive external rewarming, removal of wet clothing, insulation with blankets, is first line for mild hypothermia, 32 to 35 degrees Celsius. Active external rewarming, forced air warming, 43 degrees Celsius, is added for moderate hypothermia, 28 to 32 degrees Celsius. For severe hypothermia, less than 28 degrees Celsius, with cardiac instability, active internal rewarming via extracorporeal membrane oxygenation, ECMO, is recommended by the American Heart Association, AHA, 2020 guidelines. The risk of pulmonary edema after near drowning is 30 to 50%, often non-cardiogenic due to surfactant washout and increased alveolar permeability. Prognosis is poor if submersion duration exceeds 10 minutes, with survival rates less than 5% and favorable neurological outcome in less than 2%, resuscitation, 2021. Serum potassium greater than 12 millimoles per liter in hypothermic cardiac arrest is a reliable predictor of non-survivability and may guide futility decisions. The Utstein-style drowning registry criteria define cardiac arrest as unresponsiveness, absent breathing, and no detectable pulse, with time of submersion, rescue, and CPR initiation recorded to guide prognosis. Overview and epidemiology. Drowning is defined by the World Health Organization, WHO, as the process of experiencing respiratory impairment from submersion or immersion in liquid, with outcomes ranging from no injury to death. The ICD-10 code for accidental drowning and submersion is W65, W74, with subcategories for location, bathtub, pool, natural water, and intent, accidental, intentional, undetermined. Globally, drowning accounts for approximately 236,000 deaths annually, making it the third leading cause of unintentional injury-related death, following road traffic injuries and falls, WHO, 2023. The global age-standardized mortality rate is 3.1 per 100,000 population, with regional disparities: Southeast Asia, 4.7 per 100,000, and Africa, 4.5 per 100,000, bear the highest burden, while Europe reports 2.1 per 100,000. In the United States, drowning is the leading cause of injury-related death in children aged 1 to 4 years, with a rate of 2.8 per 100,000, CDC, 2022. Among adolescents and young adults, 15 to 24 years, drowning ranks second after motor vehicle collisions. Males are disproportionately affected, accounting for 79% of drowning deaths in the U.S., with a male-to-female ratio of 3.8 to 1. Racial disparities exist. Black children aged 5 to 19 have a drowning death rate 5.5 times higher than white children in swimming pools, CDC, 2021. attributed to disparities in swimming education and access to safe aquatic environments. Pathophysiology. Drowning initiates a cascade of respiratory, cardiovascular, and neurological insults driven by asphyxia, hypoxemia, and acidosis. Upon submersion, the victim initially holds their breath, but as arterial PaCO2 rises, typically greater than 50 mm of mercury, an involuntary reflex to breathe is triggered, leading to water aspiration. The volume of water aspirated is often small, 1 to 3 ml/kg, but sufficient to disrupt pulmonary surfactant, increase alveolar surface tension, and cause atelectasis. Both saltwater, osmolarity 1000 mosm/L, and freshwater, osmolarity 0 mosm/L, induce acute lung injury, though via different mechanisms. In freshwater drowning, hypotonic fluid is rapidly absorbed across the alveolar capillary membrane into the pulmonary interstitium and bloodstream, causing hemodilution, hyponatremia, serum Na plus less than 135 millimoles per liter, and hemolysis due to osmotic lysis of red blood cells. This can lead to hyperkalemia, K plus greater than 5.5 millimoles per liter, from intracellular potassium release, increasing the risk of ventricular fibrillation. In saltwater drowning, hypertonic fluid draws plasma into the alveoli, resulting in intravascular volume depletion, hemoconcentration, and acute respiratory distress syndrome, ARDS. Despite historical distinctions, clinical outcomes are similar, with both types causing non-cardiogenic pulmonary edema in 30 to 50% of cases. Clinical presentation. The classic presentation of drowning includes a history of submersion, cough, dyspnea, and hypoxemia. Symptoms manifest immediately or within 1 to 2 hours in 95% of cases. Cough occurs in 85% of survivors, tachypnea, respiratory rate greater than 20 per minute, in 78%, and cyanosis in 42%. Mental status changes are common: confusion, GCS 9 to 13, in 35%, lethargy, GCS 4 to 8, in 22%, and coma, GCS 3, in 12%. Seizures occur in 8% and are more frequent in freshwater drowning due to hyponatremia. Atypical presentations are more common in vulnerable populations. In elderly patients, greater than 65 years, drowning may present as sudden cardiac arrest without witnessed submersion, particularly in bathtubs. Diabetics may have delayed symptom onset due to autonomic neuropathy impairing the cough reflex. Immunocompromised patients are at higher risk for secondary pneumonia, with fever, T greater than 38 degrees Celsius, developing 24 to 72 hours post-event in 18%. Key points: GCS less than or equal to 8, indicating need for intubation. SpO2 less than 90% on room air, indicating respiratory failure. Asystole or pulseless electrical activity, PEA, on ECG. Core temperature less than 30 degrees Celsius with cardiac instability. Diagnosis. Diagnosis of drowning is primarily clinical, based on history of submersion and respiratory symptoms. The Utstein-style drowning registry criteria require documentation of time of submersion, rescue, CPR initiation, return of spontaneous circulation, ROSC, and hospital admission. Laboratory workup includes key points: arterial blood gas, ABG PaO2 less than 80 mm of mercury, sensitivity 91%, PaCO2 greater than 45 mm of mercury, 68%, pH less than 7.35, 75%. Electrolytes, Na plus less than 135 or greater than 145 millimoles per liter, K plus greater than 5.5 millimoles per liter, lactate, greater than 4 millimoles per liter, predicts mortality, AUC 0.84. Creatinine kinase, CK greater than 1000 U/L suggests rhabdomyolysis. Management and treatment. Immediate priorities follow the ABCs with emphasis on airway and oxygenation. All patients should receive high-flow oxygen, 15 liters per minute via non-rebreather mask, to target SpO2 greater than or equal to 94%. Endotracheal intubation is indicated for GCS less than or equal to 8, respiratory rate less than 10 or greater than 30 per minute, or POW2 less than 60 mm of mercury on supplemental oxygen. Use rapid sequence intubation, RSI, with continuous monitoring includes ECG, pulse oximetry, non-invasive blood pressure every 5 minutes in unstable patients, and core temperature. Insert 2 large bore 4 lines, 16 to 18 G. Avoid aggressive fluid resuscitation. Administer isotonic crystalloid, 0.9% NaCl, only if hypotensive, SBP less than 90 mm of mercury, at 10 ml per kilogram bolus, repeated once if needed. Avoid lactated ringers due to potassium content. Key points: etomidate 0.3 mg per kilogram 4, range 0.2 to 0.6 mg/kg, preferred due to hemodynamic stability. Succinylcholine 1.5 mg per kilogram 4, max 200 mg, contraindicated if K plus greater than 5.5 millimoles per liter or burns. Use rocuronium 1.2 mg per kilogram 4 instead. Avoid hyperventilation. Target PACO 235 to 45 mm of mercury to prevent cerebral vasoconstriction. Passive external rewarming, remove wet clothing, insulate with blankets, move to warm environment. Effective for mild hypothermia, 32 to 35 degrees Celsius, rewarming rate 0.5 degrees C/H. References: 1. Claude et al. Drowning complicated by hypothermia. Journal of Education and Teaching in Emergency Medicine. 2025, 10, 1S43S74. PMID, 399262253, https://pubmed.ncbi.nlm.nih.gov/399262253. doi 10.21980/J8QS7P. 2. Andre MC et al. Rewarming young children after drowning-associated hypothermia and out-of-hospital cardiac arrest, analysis using the case report guideline. Pediatric Critical Care Medicine, a journal of the Society of Critical Care Medicine and the World Federation of Pediatric Intensive and Critical Care Societies. 2023, 24, 9E417E424. PMID, 371333324, https://pubmed.ncbi.nlm.nih.gov/371333324. doi 10.1097/PCC.0000000000003254. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.